In a complete physical examination, the general principle is to proceed in the sequence of inspection, palpation, percussion, and auscultation, moving from head to toe to ensure that no part of the body is overlooked. There is one important exception to this rule. When examining the abdomen, the order changes to inspection, auscultation, percussion, and finally palpation. This adjustment is necessary because palpation before auscultation may alter peristaltic sounds or cause involuntary contractions of smooth muscles, thereby interfering with the accuracy of auscultation. Inspection is always the first step. The examiner uncovers the part of the body to be observed and carefully notes its color, shape, contour, size, and movement. Direct inspection relies on sight, hearing, and smell, while indirect inspection uses instruments such as otoscopes, vaginal specula, or ophthalmoscopes to visualize internal structures. Following inspection, palpation is performed to assess structures that cannot be fully appreciated by the eyes alone. Through touch, the examiner identifies pulsations, vibrations, the position and size of organs, their outlines, and any tenderness. Although palpation normally follows inspection, in the abdominal and urogenital examinations, it comes after auscultation for the reasons already explained. Palpation itself takes several forms. Light palpation uses the fingertips to gently press 1 to 2 centimeters to detect surface abnormalities. Superficial ballottement involves laying the hand lightly on the skin to feel for the rebound of tissues, often employed across the abdomen. Deep palpation requires one hand placed over the other, pressing approximately 4 centimeters to assess deeper organs. A clinical sign known as rebound tenderness is tested by pressing slowly and releasing quickly. Pain upon release indicates irritation of the peritoneum. Deep ballottement is carried out by applying firm pressure and then slowly reducing it while keeping the fingertips in contact with the skin, sensing the returning movement of deeper structures. Bimanual palpation uses both hands together, one hand to stabilize an organ or mass and the other to feel its contour. After palpation, percussion helps to define the boundaries, size, and consistency of organs. By tapping with fingers or the hand, the examiner elicits characteristic sounds. A flat sound suggests dense structures such as muscle or bone. Dullness is heard over the liver, spleen, or heart. Resonance is typical of healthy lung tissue. Hyperresonance may indicate emphysematous lungs or the lungs of children. Tympany occurs when tapping over air-filled structures such as the stomach, intestines, or bladder. Percussion is essential in evaluating the size of the liver, determining fluid accumulation in ascites, or confirming the movement of dullness with changes in position. Finally, auscultation is performed to listen for sounds produced by the heart, lungs, vessels, and intestines. A stethoscope is used for this purpose, and its two sides serve different functions. The bell is designed to capture low-pitched sounds, such as heart murmurs or vascular bruits, while the diaphragm is suited for high-pitched sounds like the first and second heart sounds, as well as lung and bowel sounds. Preparation for physical examination is as important as the sequence itself. The examiner should explain the purpose and methods to the patient, provide adequate privacy, and expose only the area under examination, especially in elderly individuals who may require more time. The environment should be comfortable and private. The choice of patient position also depends on the system under examination. The sitting or supine position is used for the head, neck, thorax, breast, upper extremities, and heart. Standing reveals posture, balance, spinal alignment, or varicose veins. The dorsal recumbent position is used for abdominal and gynecologic assessment. Lithotomy position facilitates examination of the bladder, rectum, perineum, and genitalia. Sims position is used for rectal examination, while prone positioning assists in musculoskeletal assessment such as hip extension. Left lateral recumbent positioning is preferred for heart sounds. The knee chest position allows optimal exposure of the rectum. This systematic approach ensures that physical examination proceeds in a logical, efficient, and patient-centered manner, maximizing the accuracy of findings while minimizing patient discomfort. During the physical examination, the skin is first observed for its overall color, vascular distribution, the presence or absence of lesions, its texture, thickness, and surface temperature, as well as the condition of the nails. A normal finding is a healthy pink tone with skin that feels moist, soft, warm, and elastic. The nails should also be pink, smooth, and firm, with body hair evenly distributed across the skin. The examination of the head and neck includes assessing the cleanliness of the scalp, noting whether there are any lesions, tenderness of the skull, or palpable masses. The face is checked to confirm that it appears symmetrical and that no involuntary movements are present. The neck should also be symmetrical, moving smoothly without restriction, and the thyroid gland should not be palpable. Lymph nodes are palpated carefully to ensure that no abnormal masses or tenderness are detected. A normal finding is evenly distributed hair, a clean scalp without lesions, a symmetrical face, a centrally located trachea, a thyroid gland that cannot be felt on palpation, and no palpable lymph nodes or tenderness. Examination of the thyroid requires the examiner to stand behind the patient, placing 2 or 3 fingers just below the larynx, and asking the patient to swallow while observing for upward movement of the gland. Each lobe is palpated by gently shifting the trachea while the patient swallows. The cervical lymph nodes that must be checked include the laryngeal, parotid, supraclavicular, oral, submandibular, and posterior cervical nodes. For the eyes, several structured tests are performed. Visual acuity, governed by the second cranial nerve, is measured with the patient wearing corrective lenses first and then without. Each eye is tested separately, beginning with larger letters on the chart and progressing to the smallest line that can be read. Peripheral vision is tested by having the examiner and patient sit facing each other at a distance of 60 to 90 centimeters, covering the opposite eye, and slowly moving an object from the periphery toward the center, asking the patient to indicate when it first becomes visible. The pupillary light reflex, controlled by the second and third cranial nerves, is assessed in a dim room as the patient gazes straight ahead while a light is directed into the pupil. The examiner observes whether both pupils constrict briskly and symmetrically. Extraocular muscle function, involving cranial nerves 3, 4, and 6, is evaluated by asking the patient to fix the head while following the examiner's finger or object in 6 directions of gaze. Internal structures are examined with an ophthalmoscope, adjusting the lens dial to focus clearly on the retina, optic disc, and vessels. The optic disc's shape, color, size, and vascular pattern are carefully inspected, using the right eye of the examiner to assess the patient's right eye and the left for the left. Strabismus is detected with the cover test and corneal reflex testing. Normal ocular findings include visual acuity of 20 by 20 in both eyes at a distance of 6 meters, intact visual fields, equal and reactive corneal reflexes, normal and coordinated eye movements, absence of nystagmus, a clear and soft cornea, and round, regular irises. On ophthalmoscopic examination, both eyes should display a bright, round, orange-red reflex through the pupil. The optic disc should appear yellow-orange to pale pink with clearly defined margins, central vessels in a 2:3 ratio of artery to vein, and a shallow central depression. The retina should appear pink with the macula visible as a vessel-free area located about 2 disc diameters away from the optic disc. In hypertensive patients, swelling of the optic disc may be observed. The corneal reflex is a test of the 5th cranial nerve, and normal intraocular pressure ranges from 12 to 25 millimeters of mercury. Elevated pressure, as in glaucoma, may produce headache and vomiting, making it an important clinical sign. When examining the ears, both ears should appear symmetrical, and the tympanic membranes should be clearly visible with distinct borders. Any hearing impairment may be due to either conductive or sensorineural causes. Conductive hearing loss occurs when sound waves are blocked from traveling through the external ear to the cochlea of the inner ear, as in cases of ear canal swelling, tympanic membrane rupture, or otitis media. Sensorineural loss, on the other hand, is related to damage of the auditory nerve. Specific tests are used to differentiate these. The Rinne test compares bone conduction and air conduction, identifying whether the problem lies in the middle or inner ear, while the Weber test uses bone conduction at the forehead to detect asymmetry in the auditory nerve pathways. Normal Rinne results show air conduction twice as long as bone conduction, Whereas in sensorineural loss, air conduction remains longer, but perception is reduced overall. The Weber test should reveal sound heard equally in both ears if hearing is normal. If lateralized, it suggests conductive or sensorineural deficits depending on the direction. Normal vestibular function, controlled by the 8th cranial nerve, is also confirmed during the ear examination. In children, the ear is pulled downward and backward during inspection to straighten the canal for better visualization. The nose is assessed for the symmetry of both nostrils and the patient's ability to perceive smell. Normally, the nostrils are symmetrical. The nasal mucosa is moist and pink, with no lesions or abnormal secretions. Palpation over the paranasal sinuses, particularly the frontal and maxillary sinuses, should not produce tenderness. A detailed ear exam includes palpation of the anterior and posterior aspects of the external ear, the mastoid process, and the auricle. The ear canal and tympanic membrane are examined with an otoscope. Hearing is screened by holding a ticking watch 2 to 5 centimeters from one ear while the opposite ear is occluded, then repeating on the other side. The RIN test is conducted by striking a tuning fork, placing it on the mastoid process until the patient no longer hears the sound, and then holding it in front of the ear canal. Normally, air conduction lasts about twice as long as bone conduction. The Weber test is performed by placing the vibrating tuning fork on the midline of the forehead. In a normal result, sound is perceived equally in both ears. The oral cavity and pharynx are inspected for the color, symmetry, and moisture of the lips and gums. The teeth are checked for looseness, decay, or discoloration. The tongue is observed for its central position, symmetry, movement, and surface characteristics, and gently palpated. A normal finding includes no tenderness in the temporomandibular joint, 28 intact teeth without caries, a tongue located centrally and moving symmetrically, and a midline uvula. The tonsil should appear pink without hypertrophy. Oral examination requires basic tools such as a tongue depressor, gauze, gloves, and a cup of cold water for rinsing. When it comes to chest and lungs, the shape of the chest wall is first inspected, noting the anteroposterior diameter, symmetry, and overall breathing pattern. On the posterior chest, palpation begins along the spinous processes from the 7th cervical to the 12th thoracic vertebra, including the scapulae and surrounding muscles. The patient is asked to say 1, 2, 3, while the examiner places the palms on the lower back and lateral chest to compare tactile fremitus on both sides. During deep breathing, the examiner palpates the chest expansion. Percussion proceeds downward, comparing sounds side to side and checking the range of diaphragmatic movement. Auscultation follows from the upper to the lower lung fields, while the patient breathes slowly through the mouth. On the anterior chest, palpation includes assessment of tactile fremitus, the suprasternal notch, sternal angle, costal angle, and ribs. Percussion is performed downward, carefully comparing both sides, avoiding breast tissue or bony prominences. Auscultation covers the anterior chest from the apices to the bases of the lungs. Normal findings include respiratory rate of 14 to 20 breaths per minute without difficulty, a chest that is elliptical in shape with the anteroposterior diameter shorter than the transverse, ratio 5 to 7, and equal tactile fremitus on both sides. Percussion produces resonance throughout, and auscultation reveals normal vesicular breath sounds in both lungs. The presence of adventitious sounds such as crackles or wheezes is abnormal. During inspection in heart and peripheral vascular system, with the patient lying supine or at a 20 to 45 degree angle, the examiner checks for cyanosis or edema. Palpation follows, assessing pulsations at the aortic, pulmonic, right ventricular, and apical areas. The apical impulse is located at the intersection of the 5th intercostal space and the midclavicular line. Abdominal aortic pulsations are also noted. Peripheral pulses, carotid, radial, femoral, dorsalis pedis, and posterior tibial, are palpated for symmetry, strength, and regularity. Auscultation is performed while measuring blood pressure at the brachial and popliteal arteries, listening for systolic and diastolic phases, as well as murmurs, their intensity, pitch, and radiation. The first heart sound, S1, produced by closure of the mitral and tricuspid valves during systole, is heard best at the second intercostal spaces beside the sternum. The second heart sound, S2, from closure of the aortic and pulmonic valves during diastole, should also be clear, short, and free of murmurs. For jugular venous pressure, the examiner identifies the highest visible point of jugular pulsation and measures vertically from the sternal angle. Normal findings are short, distinct S1 and S2 sounds, no murmurs, regular rhythm, and palpable, equal pulses in all extremities. The abdominal examination begins with preparation. The patient should empty the bladder, lie in a supine position, and flex the knees slightly. The examiner warms both the hands and the stethoscope and trims fingernails short to avoid discomfort. If the patient is anxious, they are guided to breathe slowly through the mouth. The correct order is inspection, auscultation, percussion, and palpation, because palpation and percussion can interfere with normal bowel sounds. Inspection focuses on the overall appearance of the abdomen, including skin color, scars, vascular patterns, the umbilicus, and abdominal contour. Movements associated with breathing are also observed. Auscultation is carried out with the diaphragm of the stethoscope to detect the presence, frequency, and character of bowel sounds. Percussion helps to define organ boundaries. The liver is examined by percussing upward along the right midclavicular line until dullness is heard, normally 6 to 12 centimeters. The spleen is assessed near the left 10th rib along the posterior axillary line. Palpation begins lightly to check for muscle resistance, tenderness, or superficial masses. Deep palpation follows to identify deeper organs or lesions. Each quadrant is palpated systematically, and any mass is described by size, location, consistency, and tenderness. Rebound tenderness, in which pain occurs upon sudden release of pressure, suggests peritoneal irritation. Rovsing's sign, where pressing the left lower abdomen causes pain in the right lower quadrant, is a classic sign of appendicitis. Normal findings include a rounded and symmetrical abdomen, resonant bowel sounds, a palpable liver edge, dullness over the bladder, and kidneys or spleen that are not normally felt. The presence of tumors, masses, or ascites is abnormal. The breast examination begins with inspection. The examiner observes both breasts for size, contour, symmetry, skin color, venous patterns, the appearance of the areolae, and the condition of the nipples, checking for any changes or discharge. Palpation is performed in a systematic circular or clockwise manner. The elasticity around the nipple is assessed, and the nipple itself is gently pressed to check for discharge. The axillae, supraclavicular, and infraclavicular areas are also palpated to detect any enlarged lymph nodes. Normal findings include the absence of masses, retractions, skin lesions, nipple discharge, or palpable nodules. It is important to remember that the upper outer quadrant is the most common site for breast cancer. Self-examination is recommended monthly after puberty, ideally within 1 week after menstruation. The steps include standing in front of a mirror to observe symmetry, raising both arms to check for changes, pressing the hands onto the waist to tense the chest muscles and reveal distortions, and finally palpating each breast while lying down. The flat pads of the fingers are used to move in circular motions, ensuring that all breast tissue is covered. Male genital examination. Normal findings for the male genitalia include no tenderness in the scrotum, no palpable masses, and a prostate that feels firm without pain. Female genital examination. Normal findings for the female genitalia include no masses, lesions, wounds, or swelling in the external genitalia. The cervix should appear pink and firm, without masses. The vaginal wall should display folds and be free from inflammation. The uterine fundus is firm and located just below the pubic symphysis, while the ovaries and fallopian tubes are not normally palpable. Before beginning the examination, the patient is instructed to empty the bladder. In the lithotomy position, a sterile drape is placed over the patient's knees. Each step of the procedure should be explained to reduce anxiety, and both the examiner's hands and the speculum should be warmed. Lighting must be adjusted for clear visualization. During inspection of the external genitalia, the examiner checks pubic hair distribution, the mons pubis, labia, and perineum. The labia are separated to observe the clitoris, urethral opening, vaginal orifice, and mucosa for inflammation, ulcers, swelling, or discharge. During examination of the internal genitalia, 2 fingers are inserted into the vagina while the patient contracts or pushes outward to check for prolapse or incontinence. A warmed speculum is then inserted at a 45-degree angle to inspect the cervix for color, position, surface, and discharge. At this time, Pap smear and gonorrhea cultures may be collected. As the speculum is withdrawn, the vaginal walls are inspected. Bimanual palpation follows, with 2 fingers in the vagina and the other hand pressing downward on the abdomen to assess the cervix, fornices, and uterus for size, consistency, mobility, and position. The lateral vaginal walls are also palpated. The ovaries are examined by pressing one hand on the lower abdomen, while the intravaginal hand palpates laterally. A rectovaginal examination may be performed with a gloved and lubricated finger in the vagina and another in the rectum to evaluate the posterior structures. Rectal and anal examination. The patient lies on the left side with knees flexed. The examiner inspects the sacrococcygeal area and anus, then gently inserts a lubricated gloved finger toward the umbilicus, relaxing the sphincter. The rectal walls are palpated to assess mucosa, nodules, or tenderness. The patient is asked to contract the sphincter to test its strength. The examiner rotates the finger to evaluate the muscular layers surrounding the anus. Musculoskeletal examination. The musculoskeletal assessment evaluates both function and structure. Through history taking, the examiner assesses activities of daily living such as walking, standing, running, rising from a chair, combing hair, eating independently, or washing. The examiner checks for deformities, swelling, restricted range of motion, stiffness, or instability in the joints. Signs of abnormality include thickening of the synovial membrane, redness, heat, pain, or the presence of excess fluid in the joint capsule. Bone enlargement, subluxation, or contractures may also be detected. During joint movement, crepitus or friction may be felt. Muscle strength is tested, and surrounding tissues are examined for atrophy, subcutaneous nodules, as in rheumatoid arthritis, or skin changes due to inflammation. Postural alignment is also evaluated for lordosis, kyphosis, or scoliosis. Neurological examination. Assessment of brain function begins with evaluation of level of consciousness, often measured by the Glasgow Coma Scale. Eye opening is scored up to 4 points, motor response up to 6, and verbal response up to 5. Orientation is tested by asking about time, place, and person. Memory is evaluated by checking recent recall, such as events within the past 24 hours, remote recall, such as birthdays or anniversaries, and immediate memory by asking the patient to repeat numbers. Abstract reasoning is assessed by asking the patient to interpret proverbs or explain relationships between concepts. Language is checked by naming objects or responding to simple commands. Examination of the cranial nerves follows. The first cranial nerve, the olfactory nerve, is tested by asking the patient to close the eyes and identify familiar odors, checking each nostril separately. The second cranial nerve, the optic nerve, is evaluated through visual acuity testing, visual field assessment, and ophthalmoscopic examination. The third cranial nerve, the oculomotor, controls eye movement and pupillary constriction. Light reflexes are checked by shining a light into the eye to see if both pupils constrict promptly. The fourth cranial nerve, the trochlear, controls the superior oblique muscle. Its function is tested by following an object in 6 directions of gaze while checking for ptosis or nystagmus. The fifth cranial nerve, the trigeminal, carries facial sensation and controls chewing muscles. It is tested by palpating the temporalis and masseter muscles as the patient clenches the teeth, checking sensation of the forehead, cheeks, and jaw, and assessing the corneal reflex by lightly touching the cornea with cotton to elicit a blink. The seventh cranial nerve, the facial nerve, is responsible for facial expression, taste, and salivation. The examiner observes the face at rest and during expressions such as raising eyebrows, frowning, tightly closing eyes, smiling, puffing cheeks, and showing teeth. Taste on the anterior 2/3 of the tongue is tested with salt, sugar, or lemon juice. The eighth cranial nerve, The vestibula cochlear is examined for hearing and balance using the Rinne and Weber tuning fork tests. The ninth cranial nerve, the glossopharyngeal, is assessed by having the patient say, ah, or yawn, while the examiner observes the uvula rise and the soft palate elevate. The gag reflex is also tested, and taste is checked on the posterior third of the tongue. The 10th cranial nerve, the vagus nerve, shares functions with the glossopharyngeal, contributing to gag reflex, voice production, heart rate regulation, and digestive motility. The 11th cranial nerve, the spinal accessory, is tested by asking the patient to shrug shoulders against resistance and to turn the head against the examiner's hand. Finally, the 12th cranial nerve, the hypoglossal, controls tongue movement and is evaluated by asking the patient to protrude the tongue and checking for symmetry or deviation. Together, these assessments provide a comprehensive evaluation of brain function and cranial nerve integrity, essential for detecting neurological disorders. Cerebellar and motor function examination. The Romberg test evaluates balance. The patient is asked to stand with feet together and maintain position with eyes open, and then again with eyes closed. Difficulty standing still with eyes closed suggests impaired proprioception or cerebellar dysfunction. Balance is further assessed by having the patient walk heel to toe along a straight line, hop alternately on each foot, slightly bend the knees while repeating the task, or walk on tiptoes and heels. Fine motor coordination is tested through several maneuvers. The patient rapidly pronates and supinates the hands, alternately striking the knees. Another test involves extending the arms and repeatedly touching the nose with alternating index fingers, performed with eyes closed and as quickly as possible. Finger dexterity is evaluated by touching the thumb to each fingertip in quick sequence. Coordination is also examined by moving the index finger rapidly between the patient's nose and the examiner's finger. For lower extremities, the heel-to-shin test is performed as the patient, in a seated position, places the heel on the opposite shin and slides it smoothly down toward the ankle, repeating with the other leg. Sensory function examination. The examiner checks for light touch, pain sensation, and vibration sense. Higher-level sensory discrimination is tested with two-point discrimination, graphesthesia, recognition of writing traced on the skin, stereognosis, identification of objects by touch, and position sense of joints. Reflex examination. Deep tendon reflexes include the biceps reflex, triceps reflex, and brachioradialis reflex. Superficial reflexes include abdominal, knee, patellar, and ankle reflexes. Pathological reflexes are also checked. The Babinski sign, in which dorsiflexion of the big toe upon stroking the sole indicates corticospinal tract involvement, and Koenig's sign, where resistance or pain during knee extension after hip flexion may suggest meningeal irritation.